Hello and welcome to the Muskuloskeletal Seminar. We're going to go through quite a few things and introduce you to a lot of terms, and hopefully you'll learn something. So I thought we'd just start with some basic stuff. Really, I'll just go through a few basic muscles. So I want to draw an Arnold Schwarzenegger here, circa 1975 or something like that. There's your pectoralis major, and underneath that one is your pectoralis minor, actually. And this muscle here, where we do intramuscular injections, is the deltoid muscle. This one here is the biceps, biceps brachiali. And this one's here, the opposite, is the triceps, thus named because it has 3 heads. Okay. The names of the muscles in the forearm are interesting. They are things like flexor digitorum profundus, flexor carpa radialis, flexor digitorum superficialis, and all that kind of thing. But right now, just consider them to be flexors. This one here on the side, what makes your arm stick out like you look like you're carrying carpet, is the latissimus dorsi muscle. And then in this area here, we've got our lovely six-pack, the abdominis rectus muscle. Okay. Any others that are briefly one, just basic ones? Okay, this vast one on the medial side of the knee is the vastus medialis, and this one here is the femoris rectus muscle, and this one here is the vastus lateralis. Okay, you do have another one called the sartorius somewhere in there, and there's the gastrocnemius, one calf muscle there, gastrocnemius, and underneath that is the soleus. Okay, and the one at the front of your tibia, that moves your tibia upwards, is the tibialis anterior. Yeah, there we go. So I hope I haven't bored you too much there. Just some interesting names of some muscles in the body and where they are. So hopefully we'll go through some more of them and you'll learn something. Enjoy. So this is just to tell us what we're going to sort of go through during this session. We're going to do a brief recap of neuro and sensory, a little quiz there to keep you all awake. We're going to do through the musculoskeletal system and some anatomy and physiology, as well as some pathology, pathophysiology, and some nursing consideration. So what's a pathology? Pathology is just when something just goes wrong, and pathophysiology is how the thing that's gone wrong goes wrong. So you've got anatomy, which is just basically a big list of things and labels, which is sort of a little bit dry. It's made a bit more interesting when you introduce physiology, which is how it works. So anatomy, what it is, physiology, how it works, pathology when it goes wrong, and pathophysiology is how and why it goes wrong. So you need to know the anatomy and the physiology in order to appreciate the pathology and then the pathophysiology. Hopefully some of this will sort of like come into play. In your mind, it's like putting together an enormous jigsaw with 1,000,000 pieces, and you just get little snippets at a time, but hopefully this will help you build the foundations of that, and you will flourish in your knowledge of anatomy, physiology, and pathology. As well as the nursing considerations, of course. So just a little recap of the neuro and endocrine quiz. Oh yes, you thought you'd finished with neuroendocrine, but no, it's come back to haunt you in a quiz. Well, your exam's going to be multiple choice questions, so you might as well do some multiple choice questions to get you used to multiple choice questions. So, what is a congenital disorder caused by incomplete closure of the neural tube? Is it spina bifida occulta, anencephaly, meningocele, or myelomeningocele? They all sound really quite familiar. The answer is, in fact, all of them. And there's just a little gif of the neural tube actually forming. Okay, so the most common one would be a spina bifida occulta. Thereafter, you've got meningocele, where some of the meninges poke out of the neural tube defect, and then if some spinal cord comes out, you've got a myelomeningocele, and if the spinal cord fails to sort of really form, you've got a situation called anencephaly, and this is usually not really compatible with life. So yeah, the most common one would be spina bifida occulta. So there we go. So where are the upper motor neurons? Let us think. Let us use our upper motor neurons to think, where are the upper motor neurons? Are they the ones at the top of your body or the bottom of your body? Or does it mean a completely different thing? Upper motor neurons, are they A, your peripheral nerves, But what does peripheral mean? Peripheral just means around the edges, towards the edges, the periphery. So your peripheral nerves will be like in your everything that's not your central nervous system actually, but there we go. Is it your brain, which is in the middle? Yeah. Your spinal cord, or is it somatic nerves? What does somatic mean? All these terms I can't control. Oh my goodness me. Somatic nerves. A somatic nerve is something that is under voluntary control. You somatically get up and move about. You somatically drink a cup of tea. Everything that's under voluntary control is somatic. So your upper motor neurons, where are they? Upper motor neurons are your brain and spinal cord. There's a small illustration of the brain and spinal cord, and what we can see is the little nerve roots that come off in the cervical spine, C1 to C8. Although there are 7 cervical vertebral bones, but there are 8 nerve roots. And how many pairs of ribs do we have? Of course, we have 12, and therefore we have 12 thoracic vertebrae. And how many lumbar vertebrae do we have? We have 5. And how many sacral do we have? We have 5 sacral nerve roots. So there's just a little, some more little facts about nerve roots and stuff. So your central nervous system is your brain and spinal cord. So the meninges. When your meninges get infected, you get a meningitis. Itis meaning inflammation because of infection. So is it the pia mater, the choroid plexus, the dura mater, or the arachnoid? Which of those are the meninges? The answer is A, C, and E. So pia mater, arachnoid, and dura mater. Okay, and there's just a little thing illustrating the meninges. So interestingly, the choroid plexus is an area within the ventricles of the brain, and that's what makes your cerebrospinal fluid. Isn't that good? So next question is, the adrenal glands produce adrenaline and noradrenaline, growth hormone, oxytocin, or insulin. What do the adrenal glands produce? Well, the clue's in the question really, isn't it? The adrenal glands produce adrenaline and noradrenaline. Actually, amongst other things, but for the context of this question, your adrenal glands are producing adrenaline. Okay? There's a nice little gif of the kidney with the adrenal glands sitting on top of the kidney like a little baseball cap. And when you chop the kidney, if you chop the adrenal gland up a little bit, you've got the middle bit, you've got the medulla, and you've got an outer bit called the cortex. And they both produce slightly different hormones, which we might go into a bit later on. So, hyperglycemia is termed as what? What is it? Is it hyperglycemia? Is it low blood glucose, low salt, high sodium, or high blood glucose? Well, if somebody's hyperactive, they're moving around more than they would normally be, aren't they? So, and if someone has hypertension, that means the blood pressure is higher than it should be. So hyper pertains to something that's increased. So hyperglycemia, glycemic tends to be referred to things like sugar. Okay, so if you have hyperglycemia, you've got anemia tends to pertain to things about the blood. So like anemia is low hemoglobin. Yeah. If you have leukemia, you have lots of unhelpful white leukocytes in your blood. Leukemia. Yeah. Emia is the blood. So high sugar in the blood. Hyperglycemia. So you should be able to work that out just by looking at the word actually. So what is it? It's high blood glucose. So the answer should be D. High blood sugar is hyperglycemia. So what we thought we'd do is put some additional stuff on here for you, because no learning is bad learning, and this is all cool stuff. So low sodium is hyponatremia, and the way you can remember that one, if anybody remembers the chemical symbol for sodium, is Na. Yeah. Does anybody know any good jokes about sodium? Nah. Okay, so low sodium is hypo for low, nat is the chemical symbol for sodium, and emia is in your blood. So low sodium is hyponatremia. Okay, high sodium therefore is hypernatremia. Can you see how this is starting to fit together now? Really, really cool. It's like word puzzles, isn't it? yes, it would be easier just to say the patient has low sodium, but because we have to learn the medical nomenclature so we can communicate with the medics, we have to say low sodium is hyponatremia. The patient is hyponatremic. He has hyponatremia. Goodness me, what should we do? We need to treat the underlying cause and correct his unnaturally bad hyponatremia. Anyway, high sodium is hypernatremia. Low glucose is hypoglycemia. Well, that stands to reason, isn't it? Hypo is low, glycemia is the glycine, the sugar in the blood. Right, what this is a little graph which illustrates the negative feedback of glucose control. So if we look at the y-axis up here against the x-axis on here, how do you remember that the up one is the y-axis? Well, if you remember, if you stand yourself with both arms above your head, you make a letter Y, don't you? Yeah, and that's how you'll remember that it's the y-axis. It's supposed to be a human. Right, so when the blood glucose goes up too high, because this line here is the normal level, so when your blood glucose is too high, you'll get some insulin released, and the insulin, what that will do, that will unlock the cells, so the body cells can now utilize the glucose. Oh, so the body cells are now utilizing the glucose, the blood glucose level drops to normal range, and that's nice. But oh no, if it continues to drop below normal range, oh no, you're now getting hypoglycemic. And if you're hypoglycemic, you need to get some glucose into you. So at this point, if you're hypoglycemic, you might start feeling a little bit crabby. Yeah. I'm certainly really quite irritable first thing in the morning when I get out of bed. It's best if people just leave me alone until I've eaten. And certainly, my daughter is the same, but she's like that all of the time. Whenever she's hungry, she grows horns. Because she's a bit hypoglycemic. So what your body will do, your body will start to release this little hormone called glucagon, and that will encourage your liver to release the stored glycogen there it's got there, and convert that into glucose, a process called gluconeogenesis, and that will increase your blood glucose level. You go, oh yeah, there we go, and then you start to feel a little bit better. But this glucagon secretion can take a while, so it is a little bit easier, literally just to have something to eat, and you will feel less crabby. I mean, I don't know why they say crabby. I mean, what's wrong with crabs? But there we go. So there's your hyperglycemia. So at this point you should have a handout. This is where we do an activity in class where we label the skeleton with what is labelled on there and see how many we can actually get. So I'd recommend that you pause the video and then have a go at doing it. So I'm going to give the answers in 3, 2, 1. No! So this first one here is your skull. I can't actually type it on, I just have to sort of like highlight it. There's your skull, with lots of your skull bones. They all have their own individual names. We might go into that later on. The jawbone there is your mandible. What this is pertaining to here, I think it might be pertaining to this bit, which is your cervical spine. Oh god, what's this? Upper limb? Yeah, well, okay, that bone there is the humerus. Okay. Humerus. It isn't very funny if you don't know what it is. Okay, I think that's just pointing to the elbow joint. The two bones in the forearm is, that one is your radius and that one is your ulna. And then we come to the bones of the hands. So you have loads of little small bones there, the carpus. Yeah, then we have our metacarpals, and then we have our phalanges. All right, we'll go into them later on. What have we got here? So on the other side we've got the clavicle, which is your collarbone. Very easily fractured is your clavicle, yeah, collarbone there. And then the sort of bone that's your shoulder blade at the back there is your scapula. This bone down the middle of your sort of breastbone, what's sometimes called the breastbone, but it's called the sternum. There's actually 3 bones to it. There's the manubrium at the top, there's the sternum in the middle, and there's the xiphoid process at the very end. Okay, then we have our ribs. How many pairs of ribs do we have? Mentioned on a previous slide. The answer is 12 pairs of ribs. And yes, of course, men and women actually do have the same number of ribs. And therefore, how many thoracic vertebrae do we have? We have 12 thoracic vertebrae. Brilliant. And how many thoracic nerves do we have coming off the spinal cord? We have 12 pairs of thoracic nerves as well. Isn't that nice? Oh, and there's the humerus. I think the other side must have been pertaining to something different, not sure. So there's our humerus. Remember, it's not very funny if you don't know what the humerus is. This one here is the radius, and the other one on the other side is the ulna. And as mentioned, there's our the carpal bone, sorry, the small bones of the carpus. These are your metacarpals, and then we have our 3 phalanges in our fingers. Okay, then we've got, oh, I missed some out there, didn't I? We have our, on the other side, so we've got our iliac crest, yeah, or the ilium. Okay, some people might call that pelvis. And this bit in here is our sacrum. And at the very end of your sacrum is your coccyx, and if anybody's ever injured your coccyx, you'll know it's your little vestigial tailbone. Frequently people sort of like tend to fall off high heel shoes whilst they've had too many Bacardi breezes and injure their coccyx. These little bits at the bottom do form part of your pelvis. This is your ischium, and the bit that sticks out there it would be literally in the middle of your buttock. So if you were to, obviously don't do this on your patients, but if you want to explore each other's anatomy, that's up to you. If you were to press a thumb into the center of the buttock, you will feel into the center of the fleshy part of the buttock, you will find a bony prominence. And that bony prominence is the ischial tuberosity. Now, the significance of that, the only reason I'm going on about that is not because I'm fascinated by bottoms. It's that if you have a patient who develops a pressure sore in the center of the buttock, and if any of you have any clinical experience, you might have seen this. It's just a circular pressure sore in the center of the buttock. The thing that's causing that, obviously, yes, the patient hasn't been tanned enough or inspected enough, but the bone that is causing that pressure against the interface with the bed is the ischial tuberosity. So it's the ischium that's causing that. Okay, we'll go back to the other side now. So we have this long bone here. The longest bone in the body is the femur, longest, strongest bone in the body. And the head thing of this femur is called the head of the femur. And below your head is your neck. So that's your femoral neck, just under there, yeah. And we have a lumpy bit on the top, which is your greater trochanter. And there is, not illustrated there, a lumpy bit underneath called the lesser trochanter. Right, then we have a kneecap. Yeah, it's not called your kneecap anymore. Now you're going to be announced as it's called your patella. 2 bones in the lower limb, frequently mispronounced. So hopefully I'm going to tell you it now, and you remember it, and you remember it forever, and you'll never forget it, and you'll be awesome, and you'll be able to pronounce it confidently. Okay, so the shin bone, the big one at the front, your shin bone that's right underneath your skin, is your tibia. And the one at the side that sort of is superficial there disappears under a muscle belly there and then comes out superficial again there. Okay, on the outside, on the lateral side, okay, that's the key word, on the lateral side is your fibula. Okay, it has an L in it and it's on the lateral side, so it's the fibula. So we have the tibia and fibula. Okay, please do try and remember that, and I'll be massively pleased, very impressed and delighted if you're able to do that. The small bones of the foot, we have the small bones of the tarsus, but we have the calcaneum and a few other bones in there, which we'll go into later on. There's our metatarsals. Here's a good one. Tarsals for toes. Remember metacarpals in the hand? It's now tarsals for toes. Yep. Then we have our little phalanges as well. So I have rambled on quite a bit there, and we will go through this in greater detail later on. But you know, believe it or not, repetition actually works for the purposes of memorizing things. So I thought if I introduce you to these things now, when it comes to the slide, at least you'll have heard them, and with it running through your brain a few more times, it increases the chances of you remembering it. So let's do this. Well, would you look at that? I went to all that trouble to name all of those things, and there they are, all labelled already on there. Yeah, so there you go. So you can pause that and you can take it in, and you can let that knowledge consolidate, sink in, and begin to soothe your brain. So that's the quiz finished. The musculoskeletal system is made up of 2 systems. Guess what? Your muscles and your bones. Musculoskeletal. So your skeleton has about 300 bones in kids and about 206 in an adult. And the reason for that is that when kids are born, a lot of the body is cartilage, and it later ossifies to become bone. The process of turning cartilage into bone is called ossification. It's important that babies are sort of like mostly cartilage, really, so that they're a bit more flexible, so they can squeeze through the birth canal without causing too much damage to themselves or to the mum. when you're grown up, your bones confuse and you become an adult with 206 bones. Right, your muscular system has about 600 muscles, and we're going to learn each one of them. No, we're not. We're just going to learn the main ones. So try not to be too upset by the prospect of learning that. And all of these things are responsible for a thing called locomotion. So your bones and your muscles help us move around, locomotion. And there's a naked man running. I'm not sure where he's going. He's been running a while. But there we go. He is engaging in a thing called locomotion. In a different context, he could be streaking, but he's actually doing locomotion. So the muscles are contracting and moving his bones and allowing him to get around. Because if he didn't have bones, he would just be a pile of stuff. And if he didn't have muscles, he would just be a pile of bones. So the things that prevent us becoming a pile of stuff is the lovely synergistic relationship between our bones and our muscles. So next we're going to talk about bone cells, different types of cells that are in the bone. Yeah, it's not just bone cells. So we have osteoblasts, which are bone-forming cells. So if you remember, blasts build. Now the builders go, and the blasts build. So remember, osteoblasts build bone. B for builders. Right. Next we have the osteocytes. These are just bone cells that are just chilling out. They're just existing. They're there. They're forming the structure of the bone. And they actually respond to the stresses that are placed upon them. It's called Wolff's law. So a bone can sort of like become strong if it's pulled in a certain direction repeatedly, because it's responding to the stresses that are placed upon it. So there you go. So osteocytes are just mature bone cells that are just hanging around and they're there. Yeah. Next we have osteoclasts. These are clearers or cutters. So your osteoclasts cut away bone, they eat away bone. So your bone itself is constantly being remodeled as we go through life, and the rate at which your bone gets remodeled differs with age. So once every couple of years, you're pretty much your entire bony architecture is replaced. It's renewed. So yeah, just a little word about osteocytes. Okay, these little osteocytes they're formed when an osteoblast becomes embedded in the bone matrix. Okay, so when it gets embedded in the bone matrix, it lies within a little pit called a lacuna. Ah, that sounds nice. The osteoblast will fall into a lacuna and become an osteocyte. Yeah, and it communicates with its surroundings through small channels called canaliculi. So it communicates using the canaliculi. So what does bone do? It has 4 functions. The functions of bone are protection. For example, your skull and your thorax protect our inner organs, our vital structures. Mineral storage. It is a nice storage for calcium. Calcium is a really important mineral. It helps catalyze enzyme reactions. So if we have far too much calcium, we'll have lots of enzyme reactions happening. And if that happens in your pancreas, you'll end up with pancreatitis. Your pancreas will start to auto-digest itself. Anyway, don't worry about that for right now. Calcium is a mineral, and it's mineral storage for your bone. Calcium's important. And support, it forms the points of attachment for our muscles and tendons to allow us to get about, to allow us to engage in the locomotion. And it's responsible for blood cell production. So your red blood cells are these biconcave discs which have a very large surface area to volume ratio. This facilitates the diffusion of oxygen and carbon dioxide. Yep, so there's our red blood cells, so this labelled on the thing there. The white blood cells have lots of different functions in what's called the innate and the adaptive immune response. Now the innate immune response is where your body will just respond in the same way each time, no matter how many times the same thing attacks it. The innate response is always the first one to respond. This is where we send in some neutrophils and they just try and eat the things that are trying to invade and hurt us. The adaptive immune response takes a little bit longer. Another one of the white blood cells will take a piece of the invading pathogen, they'll take it to a lymph node, present it to a B cell, and the B cell will look at it and go, oh yeah, I agree, this is not self, what I will do is then produce some antibodies, and the antibodies can then connect to the invading pathogen to form an antibody-antigen complex, and that can neutralize the invading pathogen, and them antigen complexes are then eaten by macrophages. But I'm not going to go into that right now because you might find that it's confusing. So your white blood cells are for your immune response. Then we have our platelets. Platelets are wonderful little cytoplasmic fragments, little pieces of cytoplasm that sort of like flake off from a big cell called a megakaryocyte. And what platelets do, they initiate what's called the clotting cascade. They only live for between 9 to 12 days, and they are inactivated by aspirin. So if you take aspirin, it stops your platelets working. The sort of precise description of that would be it prevents platelet aggregation. So it stops your platelets sticking to each other. And platelets are absolutely needed for clotting. So if you don't have any platelets, if you get a tiny wound, from that tiny wound you will bleed to death. So there we go. Neutrophils, these are the guys that are usually the first responders. These are like the little Rambo that goes in being a neutrophil, and yes, I'll fight all of the invading pathogens that are coming in to kill the human. Neutrophils live anything between 5 hours and 5 days. So there we go. So there's hematopoiesis is what the production of your blood is. So your bone marrow, in essence, is your blood factory. And it's hematopoiesis is the process of production of red cells, white cells, and platelets, and that's under control of a hormone actually called erythropoietin. Okay, hematopoiesis is to produce the blood cells overall. To produce your red blood cells, and that can be called erythropoiesis. Okay, so erythropoietin is a hormone produced by your kidney in response to low blood oxygen. Now, erythropoietin, now there's an interesting thing, sometimes referred to as EPO, and people can take erythropoietin in order to rev up their bone marrow, increase the amount of red blood cells they've got available, which therefore, by definition, increases the amount of oxygen available to one's tissues and can enhance your performance if you are engaging in aerobic activities. So it has several cases of, for example, long-distance cyclists, what's called taking this erythropoietin to stimulate their bone marrow. That is dangerous, of course. One of the main dangers would be death, something which you can't really recover from. What happens is if you rev up your bone marrow to make lots more red blood cells, your blood becomes a little bit more crowded and a little bit thicker. And if blood becomes too thick, it can clot. Yeah, and if it clots, you get things like DVT, PE, MI, and stroke, what's the CVA, all of those things which we'll probably go into. So people who do this are actually risking their lives. So what they need to ask themselves is your life worth a bicycle race or something like that? And it isn't. So there we go. So there's hematopoiesis, production of your blood. Your red blood cells, and your platelets, all made in the bone marrow, which is your blood factory. So here's a look at some bone marrow. Quite like this image. So what we see on the outside of the bone, sort of like this pink stuff, this is your articular cartilage, and there's some sort of bits of articular cartilage there. Articular cartilage just means it's the cartilage that's on the end of the bone that is in the joint. So when it articulates like an articulated lorry. And I'm going to draw a little line here on this white bit. So this bit there, right, is very, very tough bone. So the outer sort of wrapper of this piece of bone is called cortical bone. Okay, cortical bone is very, very tough and very, very strong, very dense. You can see it's much more densely packed than like this, for instance. Okay, so this is our cortical bone, and then inside here we have all of these sort of like loose little circular bits that look like honeycomb, don't they? They look like a crunchy bar. Okay, this is what's called cancellous bone. So the bit that's in the middle is the cancellous bone, and the bit that's on the outside there is called the cortical bone. Now, when you look at this, the inside of the bone does look red, and it's red because it's red bone marrow and it makes red blood cells. But also in this bit, there's a bit of yellow stuff here, isn't there? See the yellow circle there? That's yellow bone marrow, thus called because it's yellow. It contains more fat cells, and the fat is actually yellow. So your red blood cells, the cancellous bone, the red blood cells in the middle of the bone. The cancellous bone is your bone marrow, and it makes your red blood cells. And the yellow marrow is just fat. And the differences between the two do change throughout life. So it does have the ability to increase or decrease the quantity of yellow marrow that you've got there, depending on what stresses are placed upon the bone. Hematopoiesis, which is the production of your red blood cells, occurs mainly in your long bones, like your humerus and your femur and your tibia, but it can occur outside the bone marrow in some pathological states, such as a state called myelofibrosis, or an anemia called thalassemia, or hemolytic anemia. The places where it happens outside the bone marrow can be sort of like really quite widespread, and include areas like the liver, the spleen, and the lymph nodes. That will be called extramedullary hematopoiesis. Wow, that sounds really, really posh, doesn't it? We can break it down though, can't you? Extramedullary, outside the bone medulla, hematopoiesis. Heme, blood, you think of the atopoiesis, production. So outside the bone marrow production of blood. So extramedullary hematopoiesis sounds a lot more sort of posh and learned, but when you break the words down, they're really, really quite straightforward. So to summarize, your red bone marrow makes red blood cells, platelets, and most of your white blood cells. They arise in the red marrow, and the yellow marrow is just yellow because it has a high number of fat cells. So bone structure. So we'll have another closer look at the bone. So the tough bit on the outside is here's a little compact bone, but this is your cortical bone. Okay, the correct term to use is your cortical bone, and this bit, the softer bit, is the cancellous bone, not cancerous, cancellous. Okay. Cortical bone is hard and durable. Cancellous bone has a spongy interior. So when you look on the outside of the bone here, this is a beautiful analogy. If you're eating a crunchy bar, the outside is your cortical bone, the tough bit, and the inside, the sort of softer honeycomb center, is the cancellous bone. So that's how you remember that. It's like eating a crunchy. You'll never look at a crunchy the same way again, will you? Here's an example of a ball and socket joint. This is a femur, and its socket it sits in is called the acetabulum. And if you look at the bone closely, you can see little stress lines. Right? These little lines going in this direction. It's where the bone is responding to the stresses that are placed upon it. Yeah, you might think, what on earth is this man drawing here? But if you rewind this and play this again, you'll be able to see that there's literally stress lines in the femur, and this is the bone responding to the stresses that are placed upon it. Okay, and that will be your Wolff's law that we mentioned on a previous slide. Pretty cool, pretty awesome. So there's an actual piece of bone from a live human, a removed femoral head with the red bone marrow, which makes your red blood cells, white blood cells and platelets, and your yellow bone marrow, which is mostly fat. And this here is an example of some cancellous bones. This is a very close-up view of the spongy bone that's in the middle. So you can see it's really quite porous and lots of holes in it. So it's a lot weaker than the tough, compact cancellous bone. Good. So we're now going to discuss the axial skeleton. Okay, so the axial skeleton is your skull, your rib cage, and your vertebral column. So here is one skull. So we've got a bone at the front here, and it's nicely named the frontal bone. And one nice thing about the bones of the skull, they are named after the lobes of the brain that they sit over. Okay, so if you know the frontal bone, you'll know that this is your frontal lobe of your brain. And then this bit here is one's parietal bone, and guess which lobe that sits over? You've guessed it, the parietal lobe. At the back of your head in your occiput, okay, you have your occipital lobe of the brain, and right over your temple where your ears are, you've got your temporal bone, and therefore your temporal lobe. There isn't a sphenoid lobe, okay, but like, so you've got a frontal, a parietal, occipital, and a temporal lobe. Other bones of the skull, okay, we've got our nasal bone sort of at the front where your nose is, okay, and we have some again, a little ethmoid bone in there, okay, there's a little sinus in there. The lacrimal bone, is sort of like near where your lacrimal gland is and your lacrimal ducts, and lacrimation is the production of tears. The bit above you, sort of like where your teeth sit in, is called your maxilla, and the jawbone itself is called the mandible. A little bonus point there, there's a little hole in the mandible there, okay, where a blood vessel does go in and out, and it's called the mental foramen, which I think is quite mental, but there you go, it's the mental foramen. So next you've got the sternum, okay, and collectively it's called the sternum or the breastbone, but it's three bones. It's the top one is called the manubrium, and the middle bit is called the sternal body or sternum, and the xiphoid process is the sort of like the bit at the very, very end. You can probably feel your own xiphoid process in the midline in your own body. It's a sort of like a tiny little lumpy bit that sticks up just before your last rib starts. Okay, so there it is with regards to the thorax, and it's good to note that the T12 is the 12th rib, which is a floating rib, and you've got 12 pairs of ribs. Everybody has 12 pairs of ribs, unless you have any removed, of course. Then we come to the spine, so we've got the skull, the rib cage, and the vertebral column. So we've done the skull, we've done the rib cage, now we're going to do the vertebral column. So we have the bit near your neck, which is your cervical vertebra, okay, the bit near your thorax, where all of your ribs are, which is your thoracic vertebra, and the bit in your lumbar spine, where you have your lumbar vertebra, and the bit over your sacrum, which is your sacral vertebra, which are all fused in an adult, and the bit at the bottom, your little vestigial tail, is your coccyx. So there are curvatures of the spine actually. Can you see that this image has curves in it? These are your natural curvatures of the spine, and they have names. So the bit that sticks forward like that, like the gut of a big fat lord, is cervical lordosis. Then our thorax sticks sort of backwards there, and that's called thoracic kyphosis. The kyphosis is a deformity you may quite see frequently in elderly patients, usually elderly postmenopausal ladies, for reasons that we'll describe on further slides. But you can get like almost a little hump on your back called a dowager's hump, and that's just sort of increased thoracic kyphosis. And remember, in the cervical spine we said there was cervical lordosis. Well, the lumbar spine has that same shape, sticking forward like the gut of a big fat lord. So that's lumbar lordosis. So the three natural curvatures of your spine are cervical lordosis, thoracic kyphosis, and lumbar lordosis. Yes, that does sound like something like a Harry Potter spell or something like that, but these are good things to know, and it's really, really funny if you try and pronounce some of these things after you've had a few drinks, perhaps. That's if you do drink. If you don't, just have fun pronouncing them, or getting your friends who are drunk to try and pronounce them as well. So we've done the axial skeleton, which is the bit on the middle. Now we're going to do the appendicular skeleton, like our appendages, that's our arms and our legs. So the upper limb and pectoral girdle, and the lower limb and pelvic girdle. So the upper limb, I'll just draw on these things here. We've got the clavicle, which is a collarbone, but it's called the clavicle. All right. Your shoulder blade, or its proper name, is the scapula. All right. Remember that bone? It's not very funny if you don't know it. It's your humerus, and the one that goes from the base of the thumb around to the outside of your elbow is your radius, and the one where you put your hand up to defend yourself if someone's going to strike you, because you can get a defensive injury, you can get a little fracture of your distal ulna called the nightstick fracture. If you were struck with a nightstick by a person wielding something, that's your ulna for, oh, it hurt there when he hit me. Oh. Then we have our little carpal bones, 2 rows. Okay, scaphoid, lunate, tricurum, pisciform, trapezium, trapezoid, capitate, and hamate, but don't worry about that for now. Then we have our metacarpals. Yeah, they may have our proximal, middle, and distal phalanges, and in your thumb you've got a proximal and a distal phalange. Yeah, so that's the upper limb. Lower limb, we have our ischium here, we have our sacrum here. Okay, it's not the ischium, idiot, I'm sorry, it's the iliac crest. We're an idiot, sorry. There's your ischium at the bottom there. Okay, and I've already mentioned your sacrum. We have our femur with our femoral head, below your head is your neck, and we have the greater trochanter at the top and the lesser trochanter at the bottom, and we have our femoral shaft. Okay, and there's your femur, and there's the lower limb bone there, which is the tibia, and the one with the L in it on the lateral side is the fibula. Then we have our small bones of the tarsus. Okay, so your heel bone will be your calcaneum, the bone that articulates between the sort of underneath the tibia and alongside the fibula is the talus. In front of those, you've got your navicular, your cuboid, and 3 cuneiform bones. Then we have our metatarsals for toes, and then we have our phalanges again. Okay, remember tarsals for toes. Nice and easy. Metacarpals for hands, and tarsals for toes. Apologies for the error later on. Alright, goody good. Next slide. So, the joy of the small bones of the foot. It's not quite as complicated as it looks. Alright, so your shin bone sort of ends in a lumpy bit on the inside of your ankle. Okay, so the lumpy bit on the inside of your ankle, it's called the medial malleolus, but that's part of your tibia. And you've got a lumpy bit on the outside of your ankle, which is your fibula. Okay, and these two sort of bones articulate on top of a bone called the talus. Okay, and your talus there. And your calcaneum is a heel bone. This is a view sort of from top down. So there's your heel bone. Now they're the big ones there, but these are the other small bones of your foot. Here is a one called the navicular. All right, and the navicular means boat shaped. Now when we come to do the hand, there is an analogous bone in the hand which is shaped just like that, and in the hand it's called the scaphoid, which also means boat shaped, but in the foot it's called the navicular. All right. And then we've got this bone here, which is the cuboid. Cuboid. So that means oid means like but isn't. Okay, so that means it's like a cube but it isn't. Then we have 3 cuneiform bones. So we've got the one on the medial side, which is called the medial cuneiform. All right. You've got the one in the middle, which is the intermediate cuneiform, and you've got the one on the lateral side, which is the lateral cuneiform. Now you know the 3 small bones of your foot. Now the metatarsals themselves are just labelled 1, 2, 3, 4, and 5. Okay, so your first metatarsal, second metatarsal, third metatarsal, fourth metatarsal, fifth metatarsal. Then, as mentioned before, we have our phalanges, 1 to 5, your proximal phalanges. Okay, in the big toe you've only then got a distal phalanx. Here, A, B, C, D, you've got middle phalanges, although here it's illustrated as intermediate, but middle is completely fine. It does actually depend on who you read. And then we have the ones at the end called the distal phalanges, the ones that are in the distance, that are furthest away. So there's the small bones of the foot, the gift that I give to you. There is a little mnemonic that you can use to remember the small bones of the foot if you're finding it challenging, and that is tiger cubs need milk. Alright, tiger cubs need milk. So it's talus, calcaneum, navicular. So it's tiger cubs need milk is medial cuneiform, intermediate cuneiform, and lateral cuneiform, and the cuboid. Isn't that awesome? Enjoy. Okay, next is the small bones of the hand. Okay, now you're probably really quite sort of scared of these, really, as I was initially, but seriously, once you get these committed to memory and you revise them regularly and you get to know them, they do really come in really quite useful. Okay, so if you look at the image, we've got this one here. Remember I mentioned the navicular in the foot, that was boat shaped. Now we have a similar shaped bone in the hand called the scaphoid. This particular bone, you really need to know this one in the hand, because if you fall over and this gets injured, it has really quite poor rates of healing depending on where the fracture is, and this can really lead to a lot of long-term problems with function of the entire hand if a scaphoid fracture gets missed. So, scaphoid, and then we have one where from the side it looks a bit like the moon, so hence it's called the lunate. And then we have the triquetrum. I don't know what a triquetrum actually is. And then we have the pisiform. Some people might say pisiform because it's like taking the piss, but no, pisiform bone. And so there's your proximal carpal row. So 1, 2, 3, 4 bones in that sort of first row. Then the second row is the trapezium bone. Or that's shaped like a trapeze, I don't know. And I want a bit that's like the trapezium but isn't, so it's the trapezoid. And then the big one in the middle, this big bone, like the capital city, is the capitate. Yep. And then next to it, one that likes ham, and the hamate. And ham gets hung up on a hook, and actually the hamate has a hook, I think called the hook of hamate. And I'm not lying, it's really true. So scaphoid, lunate, tricuterine, pisiform, trapezium, trapezoid, capitate, hamate. And your lovely little mnemonic is she looks too pretty. Scaphoid, lunate, tricuterine, pisiform. Try to catch her. Trapezium, trapezoid, capitate, hamate. Isn't that easy? There is another one, you can make of it what you will, another little mnemonic. It's some lunatics try positions that they can't handle, but I'll let you interpret what you mean by what that's meant by that. So, not content with knowing the names of the bones, we're also going to reclassify them into sort of categories. These will be the long ones, called the long bones. They'll be in the long bone category, as illustrated there. There is the short bones. Guess what? They're a bit shorter. They're in the short bone category, as illustrated there. There is the, what are these? The flat bones. Yes, the flat bones are in the flat bone category, as illustrated there. And there's the irregular bones that are really quite irregular in shape. It's an interesting sort of set of circumstances, I suppose, but long bones are just long, like your humerus and your femur and stuff like that. Your short bones are the carpals and the tarsals, then weird long bones, the scaphoid, lunate, tricuterine, pisiform, trapezium, trapezoid, capitate, hamate. The calcaneum, the talus, the naviculars, the navicular, the cuboid, and the three cuneiform bones. To say with your short bones, the flat ones are the ones that are really a bit flat, like your scapula and your skull and your iliac crest, and the irregular ones are really irregular shapes, like basically your spine. So yeah, we've given you the names of the bones, and now we've classified them as well. So enjoy. So nice little recap. So what is A? Is it long, short, flat, or irregular? What is B? Long, short, flat, or irregular? What is C? Long, short, flat, irregular? And what is D? Long, short, flat, and irregular? Pause the video, have a think. Have you had a think? Okay, let's see the answers. So A is long, because it's long. B is flat, because it's flat. C is short, because it's short. And D is irregular, because it's irregular. Can you see how this just makes sense? All of orthopedics just makes sense. So growth, how does the skeleton develop? Well, it ossifies basically. So you have cartilage sort of at the ends of the long bones, which turns to bone. That's how we grow. So if you take a baby's skull, for instance, the baby's skull does have the bones of the skull, but there's a lot of cartilage in there, and that allows the head to literally be squashed a little bit as birth is given to said baby. So yeah, having your head squeezed through a really small birth canal, I'm assuming would be really quite painful and really quite stressful for all concerned, both the baby and the mother. But after 24 hours, the baby's head does sort of like start to change shape and go back to being relatively head-shaped as opposed to being a little bit cone-shaped. Okay, so here's just a pictorial example of the degrees of cartilage on harder bone. So in the first picture in the embryo, you can see the blue bit is cartilage. So the embryo bones are quite a lot of cartilage. In the young person, as a young person's growing, you have what's called centers for ossification. So this little bit here is a bit of a cancellous bone surrounded by cartilage, and in these zones sort of here, it's literally like a plate of bone that's growing. And in a plate of bone that's growing, what are they going to call it in orthopedics? What would you call a plate of bone that's growing? You call it a growth plate. Yeah. And in an adult, when growing has stopped and the growth plates fuse, it's possible sometimes to see a fine line. You see that little line there, really badly drawn? Yeah. That's where your epiphyseal growth plates have fused. When we say epiphysis, it begins with an E, the epiphysis just refers to the ends of the bone. So if you have an epiphyseal growth plate, this will be in the epiphysis. And then in a mature adult, we have the blue bit on the ends of the bones that articulates in the joint is your articular cartilage. Okay, I'll rub that off because my drawing is appalling on this computer, but we're doing our best, and hopefully staying with us. And there is a lovely little example of the bones growing, and as you watch this thing repeat itself a few times, you can see that the newborn, or the sort of 6 months old baby, the hand itself, there's loads of big gaps in between the bones, because that's the big gaps are filled with cartilage basically, and the cartilage doesn't show up on an x-ray, only sort of ossified bone shows up. And as the child grows, you can see the epiphyseal growth plates. They look like little lumpy bits on the end of the bones and little lines. And then when you reach the mature adult, them epiphyseal growth plates fuse. So that's why it's possible when you're looking at an x-ray of a hand, it's possible to tell whether or not you're looking at an x-ray of a child or a person who's still growing or an adult. It's funny to watch. If you look at the small bones of the hand, remember the proximal and distal carpal rows containing the scaphoid, lunate, tricuterum, pisiform, trapezium, trapezoid, capitate, and hamate. If you look at that in this image, you can see them sort of popping into existence one at a time as the person gets older, which is quite fun. Obviously, thereafter, after we have matured, we start to wear out, don't we? So the articular cartilage in the ends of the bones wears away just through wear and tear, and we end up in a situation where we start to develop osteoarthritis. So I think that will be discussed in upcoming slides. So what we're going to do here is look at the growth plates. Growth plates do appear as lines in the x-rays, as mentioned on the previous slide, when the patient is still growing. So there's, well, you can see that to the untrained eye, you might think that these lines here are fractures, but they're not. These are the epiphyseal growth plates. That tells you that you're looking at the x-ray of a child. Okay, it's a child's knee, and there's a wrist. We've got some arrows pointing to the epiphyseal growth plates. Okay, so in the epiphysis of bones, and there's an adult knee. Can you see the growth plates are fused? Yeah, and the gap that you see represented sort of in the joint space there, this gap it's not a gap, it's articular cartilage, which doesn't show up on an x-ray because it's not bone, it's soft tissue. There's an adult knee compared to a child's knee, and hopefully you'll see an adult wrist coming up. There we go. There's an adult wrist compared to a child's wrist. So with and without the epiphyseal growth plates. Awesome. So next we're going to talk about some bone details. So if we've got an image of a knee there, so the image on the right is the one that we're going to talk about. This bit at the top, this sort of bony thing here, is your distal femur, so that's your lateral femoral condyle and your medial femoral condyle. Okay, and then we've got a ligament there, which is at the front, and it stops your tibia coming towards the front anteriorly, and that's called the anterior cruciate ligament. Very important ligament, that, stabilizing the knee. Then we've got one behind it, posterior to it. You can see it in there is the posterior cruciate ligament, and that stops your tibia going posteriorly. That's called the posterior cruciate ligament. Then, as well as the articular cartilage on the ends of the bones in the knee, you've got these two little shock absorbers. Well, you can see them there. There's one there, and there's the other one. And these little shock absorbers absorb about 80% of the shock that goes through your knee, and they're called your meniscal cartilages because they're shaped a bit like a meniscus. All right, so meniscal cartilages in the knee absorb about 80% of the shock that goes through the knee. And if you look at the image, therefore, on the left, what we see at the top of the image here is one of the femoral condyles. Okay. And this bit here is a piece of the meniscal cartilage with a tiny little nick in it there. All right, not really anything that to get too upset about. This is just a probe instrument for sticking inside the knee and giving things a good old-fashioned tug to check their integrity. Okay, and that image that you're looking at, believe it or not, is my knee. Yeah, I had an arthroscopy and asked for the pictures so that you as students now know me a little bit more intimately. Yes. Right, okay, so bones, a little bit more to add on to the bones of the bones that we've just told you. We've already mentioned the ends of the bone are the epiphyses, okay? There's another epiphysis at the end of the bone there, and the middle of the bone is the diaphysis, okay? These terms tend not to be used that often, but at least you've heard them now, and you won't sort of freak out and go, oh, don't know what they are. Yeah, I've mentioned articular cartilage, and this is the cartilage on the ends of the bones. This is the stuff that wears away and you get your osteoarthritis. This is an adult bone because this is an epiphyseal line. It's not an epiphyseal growth plate. It's like fused. Okay, Spongy bone, wrong. It's cancellous bone, isn't it? Yes, we know that. The medullary cavity, yeah, this is the inside of the bone, the medullary cavity, where your bone marrow is, which is your blood factory, which makes your blood, which is your white blood cells, your red blood cells, and your platelets. Nutrient foramen, don't worry too much about that. Endosteum, don't worry too much about that. Periosteum, now there you go. This, in essence, is the skin on the bone. Wow, okay, this is what provides a lot of the blood supply to the bone, is the periosteum. The skin on the bone, yeah. Okay, so during childhood, when you are a child, your bone, there's a lot of metabolic processes happening there, a lot of bone growth, a lot of building going on. So the bones themselves need quite a good blood supply. So the periosteum, consequently, in kids is quite thick. And this provides quite a lot of added protection for kids, so that if your child was to fall over, the bones themselves won't shatter, they'll tend to sort of bend and then fray and then snap, a bit like a green stick. Okay, if you get some new shoots from a tree and try and snap it in half, you can't, because it'll just bend and fray and then snap. Kids' bones are similar to that, in that you can get a thing called a green stick fracture. So yes, the bone is broken, but it's a green stick fracture. So usually these can either just be casted, sometimes manipulated back into alignment. Periosteum in adults, on the other hand, goes to a little bit thinner, because there's not as much metabolic processes happening to the bony architecture. It's just maintaining itself because you're a mature adult. In those instances, if you have an injury to the bone is more likely to just crack and fracture. Okay, it's important at this point to make the distinction. If anybody says crack, fracture, break, they are all the same thing. A fracture is a fracture, right? If it's cracked, it's fractured. If it's broken, it's fractured. Okay? Fracture is a fracture, means it's broken. All right? There are different types of fractures. You can have a one that's not displaced. So if you have a one where there's just a crack in the bone, it's still fractured, but it's not displaced, so the bony alignment is maintained. So a lot of them can be treated conservatively by just popping the limb into a cast. Okay? You can have displaced fractures where the bony bits are pointing away from each other. That's still a fracture, yeah, but those ones usually need some kind of fixation to try and fix them back into place. Then you can have what's called a compound fracture. Okay, that's where the fracture's so bad the pieces of bone end up sticking through the skin. These are sort of particularly nasty types of fracture, because you get a hugely increased chance of infection there. Infection itself. Infections can be dealt with, but infection in bone can be really quite catastrophic. If you get an infection, you really don't want an infection in bone. The medical term for an infection in bone is called osteomyelitis, and it is very difficult to treat simply because the bone itself doesn't have that good a blood supply. So any bugs that get in there are quite happy to breed. And any antibiotic that you might give the patient and on the white blood cells, they find it difficult to actually get to the area to work on the invading pathogen. So frequently areas of bone that do have osteomyelitis literally need to be cut out. You need to remove it, and in some instances it can mean amputations. So osteomyelitis is really quite very serious, and you'll find that orthopedic surgeons are as hot on infection control as you could possibly imagine. Okay. Here we are then. The epiphyseal line is a remnant from bone growth. Articular cartilage reduces friction between two articulating bones, which is nice, and the older we get, the more it wears away. And when it eventually completely wears away, you end up with the gift of osteoarthritis for living long enough to wear your body out. Okay, and the periosteum is essentially the skin of the bone. Apologies to vegetarians or vegans, please close your ears now. If anybody's ever eaten a rack of ribs, when you're nibbling away at the ribs, there's sometimes this sort of like crispy stuff that's on the outside of the bone. That's actually the periosteum. And interestingly enough, the meat that you eat when you eat a rack of ribs is the intercostal muscles. And if you look sort of within that area, you will find the neurovascular bundle. So you'll find the intercostal nerve, artery, and vein as well. Enjoying a rack of ribs can also be an anatomy lesson as well. Possibly that may have put some of you off eating ribs again, but hey ho. So what I've got here is some inside the knee sort of bits. The bone that you can see is actually the distal femur. So there's one of your femoral condyles, okay, and there's the other femoral condyle. So this is the end of your femur, right? Your patella has been retracted. This big area here is a defect in the articular cartilage. Right, so you can see the articular cartilage is relatively thick, and at the bottom of this is bone, is cortical bone, the rock hard bone. And this instrument here is called a curette, and what the surgeon's doing is scraping away the defect of the cartilage so you can get to cortical bone, and hopefully to try and make it bleed a little bit, because it looks like they're going to do a chondrocyte transplant, but that's something else. Yeah, the remaining articular cartilage inside the perimeter. So this white stuff is the stuff that breaks away. It doesn't break away, it wears out as you get older, thus giving you your osteoarthritis. Additional things on this image, just of note, out of interest, are, well, there's the skin. The skin's been prepped with povidone iodine solution to sterilize it. There's an adhesive strip piece of plastic put on the skin as well. Like a steri sheet, and below the skin after it's been incised is globules. There's some globules of subcutaneous fat. So that's what your fat looks like, lumpy. So if ever you feel your own fat, if any of you have any fat, because I'm sure you're all wonderful and don't have that much fat, but everyone has some fat, so you can feel the globules of fat. And if you get a hold of one of them and squeeze it, it just basically turns into grease. So not that you would, but it just gives you an idea that it is very, very greasy. You could literally take a chunk of that, pop it in a frying pan and fry an egg with it. Here is some muscle. That's what muscle tissue looks like. And this sort of white layer here is what's called fascia. Okay, yeah, vascular, sort of not very elastic stuff. Fascia, it's stretched. This looks like bursal tissue. Okay, very, very similar in fat to fat, has sort of quite a big fat component to it, but this sort of helps things glide backwards and forwards. There's bursal tissue. Yeah, I think that's about it for that image. So I'll just get my rubber out and rub all these things off. Okay. So we've given you the names of the bones, and we've classified the bones into types of bones. And when bones articulate with other bones, they form joints. So now we'll give you some different types of joints. So all straightforward, don't get too upset by it. Okay. So the bones of your skull are held together with tough fibrous joints in what's called sutures. It looks like literally they look like they've been stitched together, but they haven't. They're just fibrous joints. Next we have cartilaginous joints, which are made predominantly of cartilage. So when you look at one's individual sternum, okay, the ends of the ribs that articulate with the sternum are quite a bit more cartilage, and that's needed to provide a little bit of flexibility so that your thoracic cavity can increase its volume and decrease its volume when you breathe. So we have cartilaginous joints. We have synovial joints, which are separated by synovial fluid. Lining a synovial joint is some tissue called synovium, and the synovium produces a fluid called synovial fluid, and that fluid looks just like that, and it's a bit like oil, really. It is very, very oily. It's like putting extra virgin olive oil in between your finger and thumb and rubbing it like that. So it provides lubrication for your joints, literally. If you have an infection in your joint and you have what's called a septic arthritis, then you can get sort of a big collection of fluid in there, and that fluid will contain a lot of white blood cells, a lot of dead white blood cells and dead bacteria, because the neutrophils have been in there and they've eaten the invading pathogen, and then it can look a bit cloudy like that. So what you've got there is pus from inside a joint that's been aspirated. Aspiration means when you stick a needle in, you suck off the fluid. It's been aspirated. So normally quite clear. If it looks cloudy like that, this is really, really bad, because septic arthritis is a surgical emergency. So there are 6 types of joints. How many of them do you think you can name? Oh my God. A type of joint? Well, not sure. Well, okay, here they are. A plane joint, a hinge joint, a condylar joint, a pivot joint, a ball and socket joint, and a saddle joint. And they are all beautifully illustrated here for you to see precisely how they work. That's the beauty of little GIF files. It gives you some moving anatomy, because if you can see it working, you will remember it. And you will remember these, because these are straightforward. So a plane joint is moving between sort of bones that have sort of really quite flat edges, really. So like, do you remember the three cuneiform bones in the foot? The medial, the middle, and the lateral cuneiforms, and the cuboid bone, and the navicular. Not a lot of movement goes on there, but these are plane joints. Okay, then we have a hinge joint. Well, what does a hinge do? Think about a door hinge when it opens. It opens so far, and then it stops, and then it closes the other way. So it just moves backwards and forwards, and that's all hinge joints do. So which joints in your body do that? Well, your elbow is a hinge joint, and so is your hip. Brilliant. Condylar joints, these are made by the joint between the metacarpal and a phalange. So your metacarpophalangeal joints, for example, your knuckles will be an example of a condylar joint. A pivot joint, this is something that just sort of like goes backwards and forwards, pivoting, and this will be your radiocapitellar joint, sort of close to your elbow, where your proximal radius articulates with the capitellum. What on earth is the capitellum, I hear you cry? Well, remember I said the humerus? It's not very funny if you don't know the name of that bone. The end of the humerus in your elbow has two sort of lumpy bits on the end. One's the capitellum, and the other one is the trochlea. So the capitellum articulates with the proximal radius, and the trochlea articulates with the proximal ulna. So there we go. There's your pivot joint. Ball and socket joint, in the body there are only two. One's your hip and one's your shoulder. And then we have saddle joint. A saddle joint literally looks like that. It's a joint at the base of your thumb. An example of that is the joint between the the first metacarpal and the trapezium is a saddle joint. So there we go. So there's your 6 different types of joints in the body. So there's an example of a hinge joint moving backwards and forwards with flexion and extension. That is one's elbow joint. Then we have a ball and socket joint, which is the most freely movable joint of all. For example, you might find this in the shoulder or the hip. So next we have some bone pathologies. Can you name any? Okay, so we have osteoarthritis. Principally speaking, this is where the articular cartilage on the ends of the bones wears away, and you get bone rubbing against bone, thus giving you osteoarthritis. Then we have rheumatoid arthritis. In essence, this is an autoimmune a disease where your body produces antibodies against your own synovial membrane, and that synovium becomes invasive and starts to eat away at the joints. So that's quite erosive. Thereafter, we've got osteoporosis. Porosis, if somebody's become more porous. Okay, osteoporosis tends to be frequently seen in postmenopausal women, where the osteoclasts assume a little bit of prominence due to the reduction in circulating estrogens, because the estrogen actually just keeps the osteoclasts in check. But when the estrogen drops off after the menopause, the osteoclasts do assume a little bit of prominence. So therefore, the females will start to reabsorb their bone at a slightly increased rate, and they will eventually get osteoporosis. We have a disease called osteogenesis imperfecta. You can break this down. Osteo, bone, genesis. Well, what's Genesis? It's the first book of the Bible. It's the beginning. Yeah. So bone beginning. Okay. So the start of bone growth. Imperfecta. That means the bone is not perfect when it grows. There's something wrong with it. So that it's a bit more brittle and it's prone to breaking. So osteogenesis imperfecta can sometimes be referred to as brittle bones disease. And then we have achondroplasia. Okay, A means without, chondro. Now, the articular cartilage that is made in your that's at the end of your bones is made by cells called chondrocytes. Oh, sorry about that. That's my alarm going off on my watch. Yeah, so we have A without. Chondro is your chondrocytes, which make articular cartilage, and plasia, which is plastic, so that it's the number of cells that are actually produced. In achondroplasia, you have a defect in ossification of bones, so the cartilage that is growing is not quite right, and in essence, you end up getting humans of very, very short stature who have normal sort of head size and things, but really quite short limbs. And the other term for achondroplasia is dwarfism, but achondroplasia is the current preferred terminology to be used. Now, what you see here in the image, which you've probably been staring at whilst my watch alarm went off, is a cross section of a foot. So this is a cadaveric dissection. So what you can see here is this big white thing here, which is not normal. It doesn't look very normal here. And then when you probably glance across the x-ray, you can see the same thing here. This is way abnormal. What this is a tumour in the foot, and it's a fibroma, and it involves the navicular and cuneiform and cuboid bones. So that's just an example of a big tumour that you might see rarely, but at least you've seen these things, because the way your brain works is if you've seen a picture, you remember it a lot easier. So osteoarthritis, rheumatoid arthritis, osteoporosis, osteogenesis imperfecta, and achondroplasia. So what is arthritis? Arthritis literally means inflammation within a joint. There you go. So on the left we have a normal joint with the bone. I think this looks like a knee probably. And the bone, and the yellow bit will be the synovial membrane. Now that synovial membrane secretes a fluid called synovial fluid, and that helps lubricate the joints. On the ends of the bones we have articular cartilage. So that's a nice, normal, healthy joint. In osteoarthritis, the articular cartilage rubs away and the bone rubs against the bone, and that's when you get your pain and deformity of osteoarthritis. In rheumatoid arthritis, the synovium becomes invasive and inflammatory, and that eats away and erodes the bone and erodes the articular cartilage. So as we said on the previous slide, osteoarthritis develops as the articular cartilage is gradually worn away over time. It's progressive and it's currently irreversible. It usually affects single joints, so if it's sort of one joint on its own, it tends to be a monoarthritis, whereas if it would affect many joints, it will be polyarthritis. So mono is one, poly is many. A monogamous individual just mates with one person for life, whereas somebody who is polygamous mates with many people. Anyway, onwards. So lifestyle changes can reduce its progression. So one of the biggest things that contributes to wear and tear on your joints is your weight. So if you lose some weight, then it can help reduce the sort of progression of it, I suppose. It is managed overall with medications and with surgery. So the image here, the left-hand side of the image is your normal joint, where you have the nice synovial capsule with its lining and articular cartilage. With osteoarthritis, the capsule can get a little bit thickened. You can get these bony deformities growing at the edges of the joints. As the bone rubs against the bone, in essence, in osteoarthritis, the body sees it as an injury, so it decides to send more bone that way, because clearly bone is being injured. So more bone is needed, and because of that, and because of the fact that the architecture of the joint is being destroyed because the articular cartilage has been worn away, you get into a situation where the extra bone starts to deform the joint. So you get bone deposition around the joint margins, and them little depositions of bone around the joint margins that lead to the deformity called osteophytes. Yeah, and you see it in the elderly population. So if you look at the distal interphalangeal joint of the fingers, you get lumpy bits on the fingers, and there can be many causes for many lumps, but one of them can be osteoarthritis. So they're little osteophytes. Okay. When it says there's sclerotic bone, that just means hard bone. So if the bone's been damaged and it's rubbing against it, and it's destroying it, it will just make it more hard. So when you take an X-ray, the X-ray of the bone of the osteoarthritic joint will look really quite white. It looks sclerotic. The joint space narrowing just really relates to the fact that the size of the joint space is going to be reduced compared to a normal one, simply because the articular cartilage is being worn away. And subchondral cysts, okay, these little small cystic things, what they are, as the articular cartilage wears away and you start to get bits of exposed bone, some of these little cells that make the articular cartilage, which are called chondrocytes, all right, they can get pushed into the subchondral bone. They get pushed into the bone, and they will continue to divide and try and make fibrocartilage. And as they do that, they form little cystic cavities called subchondral bone cysts or subchondral cysts. So the 4 signs of osteoarthritis on an X-ray are osteophyte formation, sclerosis, reduced joint space, and subchondral cyst formation. There you go. Now you can look at an X-ray anywhere in the body and tell us if there is any osteoarthritis there. Isn't that awesome? So this is just a little run through of the pathophysiology that I've just sort of described to you about the onset of osteoarthritis. So there's joint space narrowing. Fragments of cartilage can sometimes break off and just be loose bodies within the joint, really. And you end up with bone rubbing on bone, and then you've got your osteoarthritis. Subchondral sclerosis, the hardening of the bone, increased bone density. Yeah. That geode thing is your little bone cysts. Yeah, subchondral cysts. There we go. There's a progression of osteoarthritis. Marvellous. So next up, we're going to talk about rheumatoid arthritis. So in the image here, we've got on the one side a normal joint with a normal joint capsule, normal synovial lining, normal synovial cavity, and articular cartilage. Okay. So the joint capsule, literally, you see lines drawn like this, but the capsule itself on any joint extends all the way around. It is a capsule, yeah, as stated. So there's your joint capsule. On the inside of this is the synovial cavity or the synovial lining. Okay, this synovial lining has cells in it which produce a fluid. And guess what that fluid is called? It's called synovial fluid. Now this synovial fluid sort of bathes the inside of the joint space there. It lubricates it a little bit like Duckham's hypergrade oil. Okay, so it keeps your joints nice and easily movable, really. Okay, then on the ends of the bones, this blue bit here, we have articular cartilage. Okay, articular cartilage is the cartilage that's on the ends of your bones. Okay, like as an articulated wagon has a joint in it, doesn't it? So articular cartilage is the stuff that's on the ends of the bones, and you know, as you get a little bit older, this articular cartilage can wear out, and you end up with bone rubbing against bone, and that's your osteoarthritis. But we'll come to that in a bit. Okay, so what happens with rheumatoid? Well, with rheumatoid, it's an autoimmune response, basically. So your immune system takes a bit of a dislike to your synovium. Okay, so this synovium here, it just sort of doesn't like it anymore, right? And what happens is you get immune cells attacking this synovium, and it causes the synovium to try and regenerate itself because it's constantly getting attacked. And what happens is when you have an immune response to a disease, your body will send immune cells to the area to attack the pathogen. So in this instance, it's trying to attack the synovial lining of your own joint. So when it sends the cells to do that, the cells themselves have a number of different mechanisms. Your immune cells have a number of different ways of attacking an invader. One of the ways that they have is they can degranulate. And when I say that, you've got some specialized cells within your immune system which are capable. These will be killer T cells, natural killer T cells. Within their cytoplasm, they have these little granules, and they can go next to a cell, and they can basically open up their cytoplasm and release all of these granules. And the granules themselves contain little enzymes that are designed to basically attack the cell wall of other cells. So sometimes it's a pathogen, sometimes it's your own cells. And these proteolytic enzymes, they can break down proteins. They cause the cell wall of the cell being attacked to open up, and you get what's called cell lysis, and the guts of the cell spill out everywhere, and then that magnifies a bit more of a immune response, attracting other cells. So you've got that going on. Okay, and in addition to some of the innocent cells, so some of the baddies being killed, what usually happens as well is that 1 or 2 innocent bystanders are killed in the crossfire, unfortunately. So if you have a row of a billion cells and your immune system comes along and wants to attack a single cell, okay, it might attack that single cell, but a couple of cells either side usually get damaged as well. And what will happen there is that will set off a healing response in your body. So your body will want to heal. So the synovial membrane will try and replicate and continue to try and replicate. And as it does that, you get thickening of your synovium. Now,
The difference between normal synovium and synovium in your rheumatoid patient is that this thickened synovium is inflammatory synovium, and it's bringing with it an inflammatory response where not only is the cells that are being produced getting killed, but also innocent bystanders are getting killed as well. And that eventually leads to erosion. So if we look at the image here where it says rheumatoid arthritis, the bone and cartilage erosion, so the synovium, okay, increased synovial fluid, pannus formation, okay, this word pannus, I've really underlined that poorly there, okay, the pannus is basically, it's all of the invasive inflammatory synovium. So your normal synovium has replicated loads and it's very, very thickened now. And the synovium starts to grow over the articular surface. So it doesn't just stick to the place where it normally lives, which is the joint capsule. It starts to grow over the articular surface, which is really not good. And as it grows over the articular surface, it erodes and eats away at the cartilage. So you don't get hardening of the bone like you do in osteoarthritis. In rheumatoid arthritis, it just gets eaten away, so it looks a little bit softer. And the bone itself, these bone cells can end up getting eaten away as well. So you get these really, really irregular sort of patterns happening in the joint surface. So when you see an X-ray of somebody with rheumatoid, you won't see an X-ray that's very white and very hard. It'll be what's called periarticular osteopenia. That means around the joints, there'll be a lack of bone, so the X-ray won't look really, really, really white. It'll look a bit more sort of faded, really, if anything. And when it's very inflammatory and there's lots of pannus, in essence, it looks like, I don't know, like some potatoes have been mashed up by a fork. It just looks all blurred and really, really not very happy at all. So that's the mechanism. And now the thing with this being an inflammatory response, it's not restricted to just one joint in the body. If you've got rheumatoid arthritis, it will affect all of the joints, all of the synovial joints in your body get affected, okay? Some more than others. All right, so it's an autoimmune disease where the synovial membrane becomes invasive and inflammatory. Good, which is what I've just said. It's progressive and irreversible, but it is eminently treatable. Okay, so many patients live with rheumatoid arthritis and will have perfectly fulfilling lives, but if the disease is quite bad, it can be really quite debilitating. But on the other hand, we can replace many of the joints in the body anyway. Okay, so it affects many joints, usually symmetrically. So that means it would affect both joints on both sides. So it affects sort of all of the small joints in both hands, both elbows, both shoulders, both hips, knees, and ankles, and it'll also affect your spine as well. Okay, that's called polyarthritis. So more than one, many polyarthritis. It's very treatable with DMARDs. Okay, these are disease-modifying anti-rheumatic drugs. Okay, so that they sort of keep it in check a little bit. Okay, treat with medications and surgery. So we've mentioned the disease-modifying anti-rheumatic drugs, but surgeries for rheumatoid is literally joint replacement. So you'd replace the joint that's been destroyed with a prosthetic joint, and we can replace most joints in the body these days. We can do disc replacements in the spine, you can do shoulder, you can do elbow replacements and wrist replacements, and you can replace the small joints of the hand. Actually, the metacarpophalangeal joints and the interphalangeal joints, they can all be replaced, and you should hopefully be familiar with the idea that you can have a hip or a knee replacement. We can even do ankle replacements, so most of the joints in the body can be replaced. And yeah, so there we go. There's just an example of normal invasive pannus, and then the third image that you see in that series is the sort of destruction of the bone, and your patient's got equal pain in both sides there in that image there. Little notes. Yeah, top image shows synovium becoming thickened and invasive and inflammatory, and then growing over the articular surface, taking with it the inflammatory response, which ultimately destroys the articular cartilage and erodes the bone. Okay, so that's your rheumatoid arthritis. They get very characteristic features as well. They get, you can see the swellings. So in the both hands and your knuckle joints, which is your metacarpophalangeal joint, these knuckle joints in both hands on the patient will become swollen symmetrically, and you see the patient's fingers pointing off sort of like to the side. That's called ulnar deviation. The other thing that they say the invasive pannus does, as well as destroying the joint, can also destroy the tendons that might overlie a joint. So a lot of your patients with rheumatoid, they'll lose the ability to extend the fingers, to straighten the fingers, just because the extensor tendons have been eroded by this invasive pannus. Weirdly, it doesn't seem to affect the flexor tendons that much. I'm not entirely sure why, but yeah, it affects the extensor tendons quite a lot. So if you see somebody who's been sort of living for a while with rheumatoid arthritis, you will see this ulnar deviation of the metacarpophalangeal joints in both fingers, and they won't be able to extend the fingers very well either. I think that's it for this slide.
So as we mentioned on the previous slides, you should be able to look at an X-ray now and identify osteoarthritis. So there's a hip joint, ball and socket joint. So there's our femur there with the greater trochanter at the top there and the lesser trochanter at the bottom there. These are just attachments for muscles that enable you to flex and extend your hip. There's the femoral neck there, that like neck type of thing there. There's your femoral neck. And on top of your neck is your head. So I've tried to draw nicely around the femoral head there. Not very well. Acetabulum. Okay, so that's your normal joint space, or as normal I can look with my poor drawing. And the image on the right has osteoarthritis. So if you look at that really, really closely, you can see we've got the reduced joint space in there. The joint space is really, really tiny compared to the other side. And the bone here looks really white compared to the other side, so it's sclerotic. And we have these things here, these bony lumpy bits forming around the joint margins. These are osteophytes. Yeah? And if we're able to look more closely at the X-ray, we'll probably see some subchondral cysts as well. So we've got joint space narrowing, sclerosis, subchondral cysts, and osteophyte formation as well. So there's a normal hip and an osteoarthritic hip. Bone spurs, yeah, but the proper name is osteophytes. So what are the signs and symptoms of osteoarthritis? Remember, a clinical sign is something that you see, and a symptom is something that the patient experiences, right? So primarily you will have a deep achy joint, and the pain will be made worse or exacerbated by extensive use. It's better to use the word exacerbated than made worse, because exacerbated sounds a little bit more learned, and you are all gradually becoming more learned people. You will get reduced range of motion and crepitus. Okay, the crepitus is creaking and grinding of the bones. Crepitus. Stiffness during rest, sometimes called gelling. Okay, the older you get, the more you start to gel as you sit down. When I stand up after being sat on the couch for a while, I do look like early man, going from sort of walking on all fours to try and stand up straight, and you tend to make noises as well, like oh, but you have to be at least over the age of 40 to qualify to make them things. That was a joke. But yeah, stiffness during rest may develop with morning joint stiffness, usually lasting less than half an hour. So when you first get up in the morning, it can be really, really quite stiff, but once you get the synovium stimulated to make a bit more synovial fluid, it does reduce. Okay, it's diagnosed clinically and radiographically, so that by the patient's clinical presentation and the clinical signs that you see and the symptoms the patient reports, and radiographically by evidence of it on an X-ray. So here we go. Here's a picture of a hand, and you can see if you look at the metacarpophalangeal joint, that appears to have normal joint space, doesn't it? It looks nice and not too sclerotic. It looks really, that's lovely. Look at that. Oh yeah. These joints here, yeah. We've got osteophyte forming there. Yeah, we've got reduced joint space, and we've got sclerosis, which you can actually see, and we've got even the same is happening in the distal interphalangeal joints as well. Yeah, so these are osteoarthritic joints, and these ones are normal. Okay, so there's reduced joint space, sclerosis. You'll probably be able to see some subchondral cysts and osteophyte formation as well. There's an example of what the same hand actually looks like clinically. And when I mentioned earlier on them lumpy bits that you might see on the ends of the bones, and there's a lumpy bit there, and there's some lumpy bits there. This is actually deformed a little bit. This is arthritis mutilans, really. There's a name for these. Oh God, another name? Yeah. The bony lumpy bits that you see in the distal interphalangeal joints have a name. It's not going to be in your exam, but it's a bit of fun. They're called Heberden's nodes. Yep, so if your patients have the lumpy bits in the distal interphalangeal joints, they're called Heberden's nodes. And if they have them in the proximal interphalangeal joints, which are these joints here, which it does, they are called Bouchard's nodes. Of course, Mr. Bouchard, Mr. Charcot Bouchard, named them after himself. Well, you would, wouldn't you, if you're famous enough to actually discover something and classify it and name it? So yeah, Mr. Heberden and Mr. Bouchard. So Heberden's nodes in the distance, like the outer Hebrides, and Bouchard's nodes are a bit closer. So then we have a look at the foot. What we can see in the foot here is an example of what's called hallux valgus. Okay, a big bunion on there. That's a huge bunion. In the in the hallux valgus, the great toe, the big toe, moves sort of laterally towards the side. It moves in that direction. Okay, and that's called hallux valgus. That's what ladies tend to get predominantly, simply because of the shoes they wear tend to force the feet into this position. So try not to wear shoes that really disrupt your foot biomechanics, like high heel shoes. That really, anyway, back from that. And gentlemen's feet, because gentlemen tend to wear shoes that don't do that to your feet, we still get osteoarthritis in that joint, and we get it there. And there's just really, it looks a bit lumpy, more lumpy than like the rest of the joints, doesn't it? What you see there is osteophytes, and that is called, in men, that's called hallux rigiditas. So the great toe is called the hallux, yeah, or the big toe, great toe, hallux. Why give it three names? I don't know, but it has three names. So yeah, hallux valgus in ladies, valgus for ladies, where it moves laterally. That's nice, thinking out the L. And gentlemen tend to be more rigid and get hallux rigiditas. So there we go. Osteoarthritis signs. So how is the osteoarthritis treated? Well, it can be treated conservatively, which just basically means do nothing. Leave it alone. Have the patient adjust their lifestyle, have them try and lose weight and try and manage the pain that they have with pain relieving medications sometimes, or any other pain relieving interventions that you can think of, and see if they can just retain function and manage the pain as long as they can. If all else fails and the patient actually is in too much pain and has lost too much function, then you're looking at surgery. So just run through some of the things that you can actually do. So the commonly replaced joints are hips and knees. So this is a total hip replacement there, but you actually see, if you look on the other hip, there's some osteoarthritis there as well. Now this particular patient has doubled up really. They've got two hip replacements in, which is really, really cool. Additionally, they've gone the extra mile and they've had what's called a periarticular fracture. So they'll have had the hip replacement in sort of primarily, yeah. And so there's your hip replacement. And this other thing, this plate here and the screws, this long plate which goes really, really down there. It will probably go this far really. It's because there's a little fracture there. What tends to happen when you put a prosthesis in, you get what's called a stress riser at this point. So your patients can be at risk of having what's called a periprosthetic fracture. Prosthesis just means false bit. So around the end of a prosthesis, you can get the periprosthetic fracture. Now these are very difficult to manage and it's certainly a challenge surgically. So hence that's why this patient has had that plate and a load of screws put in. Okay, this is a knee replacement. So the femoral component, as you would expect, goes on the femur, and the tibial component is on the tibia. The reason the gap is still maintained as well, because there is a plastic insert that's put on called a tibial tray, and that just maintains the sort of joint space to try and give you a little bit more movement. Actually, even if you look back at that knee, look at that medial compartment of the knee there. Oh, bone rubbing against bone. Blimey, that's rampant osteoarthritis, where the lateral compartment is relatively unaffected. Yeah. And this patient's obviously read the textbook, because when you get osteoarthritis of your knee, it's usually the medial compartment that gets osteoarthritis in the first instance. Right. Ankles, yes, we can even do ankle replacement surgery. So if you look at the ankle image here, there's osteoarthritis there. You get reduced joint space, sclerosis, osteophyte formation, and probably subchondral cysts. And there's the prosthesis in place. Isn't that awesome? And we can even do elbow replacements as well. These don't really do as well because they're a lot more fiddly. Popping an elbow in is very fiddly. But there's an elbow replacement. And finally, there's a base of thumb joint replacement. So what you've got here, this is your thumb. Okay, this is your first metacarpal of your thumb, and heavily osteoarthritic. It's so sclerotic you can barely make it out. That's your trapezium. So what you do, you take out this trapezium, remove that bone there, and replace it with this lovely little prosthesis, which looks a bit like a spigot or a chest pawn that's been sort of chamfered to a point. So there's the bit that receives it. This is all in one. This is an all-in-one sort of prosthesis in one little piece that you just push into the medullary cavity of the first metacarpal. So yeah, so there's a CMC joint replacement. It stands for carpal metacarpal joint replacement. And we can even replace discs in patients' spines. Wow. Again, if you look, you can see the signs of the osteoarthritis. You've got sort of osteophytes forming on the edges of the vertebral bodies there, and you've got narrowing of the disc space. Yeah. So it all adds up to osteoarthritis. So what we do, we take out the discs, nibble a bit of bone away, and put these new discs in to maintain the disc height and reduce any nerve compression. It's awesome. So that's your joint replacements. That's common joint replacements that you're likely to see. So rheumatoid arthritis, right, this is a chronic systemic inflammatory disease of unknown cause. Don't know why some people get it, they just do. It's an autoimmune reaction that occurs leading to synovial hypertrophy, as we've already mentioned, and chronic joint inflammation, as well as the potential for extra-articular manifestations. That just basically means other things that can occur around your body. Yeah. Extra-articular means outside the joint. Manifestations are things that happen when you have rheumatoid. So you can get rheumatoid nodules, lumpy bits in the skin. It can also affect your lungs as well. Okay. In most cases, the onset is insidious. This means it's slow and gradual. It's insidious. It creeps up on you like old age. Often beginning with a fever and malaise, means the patient's a bit like, malaise. Multiple joint pains, weakness, and then the inflammation and swelling will begin. It affects many joints and it's usually symmetrical. So here's an example of a patient who's got rheumatoid arthritis. And what we see here in the fingers, these are the knuckle sort of joints, the metacarpophalangeal joints are all swollen bilaterally. And the patient's fingers have actually moved in that direction towards the ulna, haven't they? Rather than being straight out like that, this middle finger has deviated that way towards the ulna, okay? And what that's called, if it deviates towards the ulna, it's called ulnar deviation. I know. So this patient has bilateral ulnar deviation. It's a very, very common deformity seen in your rheumatoid arthritis patients, where the extensor tendons, that means the tendons that extend the fingers, normally sit across the joint just as I've drawn there. But because of this invasive pannus that's eating away at the bone, it also eats away at the tendons as well. And it causes the tendons to lose their anchoring points and literally slip into the gutter between both of the fingers into there. So that causes the finger to change its angle. That's what it is. So it's the extensor tendons, the anchoring points getting eroded, and then it just slips in the ulnar direction into the gutter and leaves your patient with this deformity. And there's an example of an X-ray. So when you look at the joints themselves, certainly if you look at the metacarpophalangeal joints of the patient's left hand there, these are just all eroded and really just there's some cysts there, but it's eroded away. There's no sclerosis. There's certainly sort of osteophytes, but it looks like it's been mashed up with a fork, as does this here. Yes, there's a little bit of sclerosis here, so it is possible to have a little bit of sort of osteo on the back of rheumatoid. But if your patient has rheumatoid factor and primarily has rheumatoid arthritis, then they'll get the rheumatoid arthritic changes that you'd expect to see. So yeah. Periarticular osteopenia, that means the bone doesn't look sclerotic, it doesn't look hard. So this is just a pictorial example using size to illustrate the frequency of bones that are affected. So 25% if your patients have the temporomandibular joint affected, so 50% is your cervical spine, 65% of your shoulder, 90%, look at that, 90% of the carpometacarpal joint and the metacarpophalangeal joints of the hand, 90%, 80% knee, 80% ankle, and 90% metatarsophalangeal joints. So the sort of knuckle joints in your hand and what would be your knuckles in your feet that are most affected by the rheumatoid arthritis. So for bonus information, can you name rheumatoid arthritis extra-articular manifestations? If you can't, don't worry. Okay, there's a lot of them on there. Don't worry. This is just to show you that rheumatoid arthritis affects a lot more than just joints. Okay, you won't be tested on the image, so just relax. I'm just going to go talk through a few of them. Okay, this is the benefit you'll have to have your nurse's dictionary. Okay, scleritis is sclera. Scleromalacia can be thinning of your sclera. Sjogren's syndrome is autoimmune, is associated with rheumatoid. You get dry eyes and dry mouth and dry mucous membranes. Lymphadenopathy is bigger lymph nodes. Pericarditis is inflammation of a pericardium. Bursitis and nodules is the rheumatoid lumpy nodules that you can sometimes see on patients, commonly seen in the elbows. Bursitis is an inflammation of the bursa, which are various sites around the body, which can lead to a lot of swelling. Tendon sheath swelling. Tenosynovitis, this is inflammation of your tendons. Amyloidosis is deposition of amyloid tissue, which basically disrupts the workings of organs throughout the body. Sensory motor polyneuropathy, sounds complicated, just means both sensation and motor sort of nerves can be affected in many nerves. Okay. Subluxation of your atlantoaxial joint. This is just there's the atlas and the axis in the sort of top of the spinal column. If they sublux, it can give you some spinal cord compression, which would not be good to have damage to the spinal cord there, because literally everything below there would be paralyzed and you'd need ventilating. From a lung point of view, you can get pleural effusions, you can get fibrosing alveolitis, where you get fibrous tissue forming in the alveoli. Kaplan syndrome, I think collectively this is called Kaplan syndrome. Small airway disease, yeah. Nodules, so the nodules you can get in the skin, you can also get in the lung. You can get a type of anemia. You can get carpal tunnel syndrome, which is compression of your median nerve at the wrist. Vasculitis in your nail folds. You can get a big spleen, a mega spleen. So when a joint is enlarged, it tends to be called its mega. So an enlarged spleen is splenomegaly. Yeah. So an enlarged liver, therefore, would be called hepatomegaly. An enlarged heart would be called cardiomegaly. Yeah. So megaly just means bigger. Felty syndrome, I'd have to look that up myself. Leg ulcers, okay, common, and ankle edema as well. Blimey. So there's lots of different extra articular manifestations of the rheumatoid arthritis. So I've just introduced you to quite a lot of new words there. Don't worry, you won't be tested on them. These are just additional explanations, really, because it's always good to try and know things. If you understand it, you understand how it works, then there's no need for memorization. People get caught up with trying to memorize lists and lists and lists. Don't. Just try and understand it, and it will come. The understanding does come. So next we have osteoporosis. So we've got normal spongy bone on the left here and osteoporotic bone on the right. So if you look at this little image, you can see there's your normal cancellous bone there. It's a little bit spaced out, but you can see how normal architecture is there. And when you're osteoporotic, it becomes increasingly porous and therefore a bit more weak and prone to fracturing. And what we have here is just a little sort of series of images which show you the progression of osteoporosis over time. So again, usually in your postmenopausal ladies, the bone just gradually gets reabsorbed and it just gets weaker and eventually it'll fracture. So that illustration there just shows you why fractured neck of femur and broken hips really are very, very common in the elderly female population. Gents do get a little bit of osteoporosis, but it's not as profound as women. And usually men are dead by the time this sort of would happen anyway. So we die first, but ladies hang around for a few more years and keep hip surgeons busy, really. So yeah, there's your osteoporosis. Okay, so this series of illustrations here, this just it illustrates the changing shape of the spine as the years advance as we go by. See the effects of osteoporosis and bone loss. See the development of a thing called thoracic kyphosis. So if you look at the thoracic spine there, as you get a bit older, it sort of like increases in sort of like hump. The bone eventually becomes so brittle that it actually fractures just under its normal physiological weight that's placed upon it. So as your patient walks, you can end up getting these, if you look at the x-ray on the right there, these little sort of compression fractures at the front of the vertebral bodies, and they're actually sort of like little wedges, wedges, so they're called, if they're at the front of the vertebral body and they form little wedges, they're actually called anterior wedge compression fractures. You get them also in the lumbar vertebra a little bit. So they're illustrated red really on the image. So your normal person will be sort of relatively upright, but when this sort of kyphosis starts to develop, the head comes a little bit further forward. Then once it's started, it will accelerate and just get worse, and the person's head will end up going even more further forward. All right, so that's the development of the kyphosis due to osteoporosis of the spine, the thoracic spine. Okay, so what we're going to show you here is a picture of a patient who's got osteoporosis, and you can see the development of kyphosis of the spine. So there's your patient. There she is on the left, looking young and vibrant, and there she is on the right, looking a little bit older, but nonetheless vibrant as well. A couple of things to point out. She hasn't gone grey over the years, which is a bonus. I don't know how some people manage that. If you see the sort of cervical spine and the thoracic spine, you see here we've got this huge, thoracic kyphosis going on. So she's developed that just as a natural part of aging. Also, there's a bit of osteoarthritis going on if you look at her hands. Yeah, the metacarpophalangeal joints have got osteoarthritic changes there. They're all swollen. So they're also lost a considerable amount of height as well. Again, that's just part of the natural progression of getting the osteoporosis. It's one of the it's a badge of honour of living to a grand old age. So yeah, well done. Okay, osteogenesis imperfecta. Right, this is a genetically inherited autosomal dominant disorder causing brittle bones. The symptoms include a blue sclera. So if you look closely at the image there, the sclera, the white of the eye, looks to be blue, but actually it isn't blue. What you are looking at is it's a thin sclera. The collagen that makes up the sclera in the patients who have osteogenesis imperfecta is a bit thinner. All right, so the sclera of the eye is a bit thinner, and what you're looking at there, it's not blue, it's the underlying choroidal vessels of the eye. So if your patient presents with fractures and you look in the eye and have a blue sclera, you're like, oh, they might have osteogenesis imperfecta. That'll be an excellent clinical sign to pick up on a kid that comes in with a fracture. So yeah, these patients will have multiple fractures and they'll have early hearing loss. And the reason for the early hearing loss is literally osteogenesis imperfecta. If you think about your anatomy of the ear, there are 3 bones of the ear. There's the malleus, the incus, and the stapes. They spell the little mnemonic, the word miss. Okay, malleus, incus, and stapes, they articulate with each other and they vibrate as your tympanic membrane, which is your eardrum, vibrates, and they send that message to that phasical vibration that change it into a sort of movement backwards and forwards where it hits an organ in your middle ear, in your inner ear, called your cochlea. But if them bones aren't conducting the sound very well, then your patient will have earlier hearing loss than you would have otherwise had. And the prognosis, which means how well the patient does, the chances of recovery, well, it's a genetic disease, so they're not going to recover from it, but what their long-term prospects are depends on what type it is. So there's lots and lots of types. The most common is type 1. Patients have a normal lifespan. Type 2 is quite severe, it can be death in the first year of life. Type 3 is really severe. Patients have many fractures starting very early in life and can have severe bone deformities. Many become wheelchair bound and usually have a shortened life expectancy. Type 4 is similar to type 1, although persons with type 4 often need braces or crutches to walk. Life expectancy is normal or near normal. And there are lots of other types, but and each one of them has their own subclassifications. There's an image just showing you some of the deformities that you might expect to see in the above that I've just described. This sounds like a lot of information, but really, if I was revising this for the exam, just revise really that osteogenesis imperfecta. Your patient has brittle bones, and they're more prone to fractures. And when you look at them, they'll have a blue sclera, and they might have early hearing loss as well. So that's really, don't get worried about all this type 1, type 2, type 3, type 4 stuff right now. Just try and get into your head that osteogenesis imperfecta is brittle bones disease, really. Achondroplasia. All right, this is a bone growth disorder affecting 1 in 15,000 to 1 in 40,000 births. It's an autosomal dominant condition, but 80% of cases are due to a brand new mutation, so they're just unexpected, they just happen. What is the life expectancy and intelligence of patients with achondroplasia? It is completely normal. Okay, might your patient really have a challenging time psychosocially? Absolutely, because the world is not made for short people, is it? It's not made for people who are short. It's made for people who are of average height, so everything tends to be out of reach. You've got to remember your patients that are living with achondroplasia have absolutely normal intelligence and normal life expectancy. Some of the characteristic features that you might see is a large head with a prominent forehead, a normal sized torso but short arms and legs. and famous people. There's a lady there, I forget her name. She's represented Britain at the Olympics, and there's Warwick Davis there. He's made himself really, really famous by appearing on TV, and I suppose raising a lot of awareness about achondroplasia as well. So good work, Mr. Davis. So muscle tissue, how many types? Well, there are 3: cardiac, skeletal, and smooth. So our skeletal muscles attach to the skeleton, and contraction of the skeletal muscle causes the bones which they're attached to move, allowing your body to perform a variety of motor activities. Skeletal muscle that supports homeostasis include those important in chewing and swallowing of food. Skeletal muscle contraction is also important for temperature regulation, and they're also used for non-homeostatic activities such as dancing. Smooth muscle is found in the walls of hollow organs and tubes. And controlled contraction of smooth muscle is responsible for the regulation of movement of blood through blood vessels. We have a thing called vasoconstriction and vasodilatation. So vasoconstriction can make your peripheries cold. It can increase your blood pressure when it's needed to, and vasodilation can help you get rid of heat. So if you need to get rid of heat to cool down, you can vasodilate, and that will lower your blood pressure and make you look a bit flushed. Okay. It can also facilitate with the contraction of smooth muscle as food getting pushed through your digestive tract, and smooth muscle is responsible for your breathing as well. It's like air through the respiratory tract, and help propel urine to the outside world when you have a wee. Cardiac muscle is found in the walls of the heart, and the contraction basically pumps the blood around the body. Without it, we would be dead. So there are more than 600 skeletal muscles. So what do you think the function of muscle is? Lots of muscles going on there. Okay, function of muscle is to produce movement, maintain posture, stabilize joints, and produce heat. That's your muscles. Yeah, that's important to remember as well. Help you move, maintain your posture, stabilize joints, and produce heat. So a bit of pathology, muscle and tendon injury. The GIF file on the right hand side of the slide shows a Achilles tendon rupture. This poor person's rupturing their left Achilles tendon. So when it goes back to the patient jumping up and down, as she hits the ground, when it goes in slow motion, as her left heel hits the ground, you'll see the Achilles tendon snap, and you'll see it shoot up the leg. It's a very, very painful injury. So we have sprains, strains, pulls, tears, and ruptures. Oh, let's have a look at this now. Left leg hits the ground and ping, there it goes. Yep. That's a ruptured Achilles. We've got grade 1, grade 2, and grade 3. So you've got stretched, partially torn, and ruptured. Now, stretched and partially torn are going to be very, very painful. Ruptured might not be painful at all, just because all of the nerve endings have been avulsed, they're being pulled off. And the degree of extra movement that you get with stretched and partially torn is very difficult to differentiate, because the patient will be in quite a lot of pain anyway. But ruptured, you get a lot of movement, a lot of abnormal movement in a joint. So just to sort of reiterate that tendons join muscle to bone. So a tendon joins a muscle to a bone, like your Achilles tendon. Yep. And ligaments join bone to bone. So the image illustrated there is the medial collateral ligament of the knee, and that joins bone to bone. So ligaments join bone to bone, and tendons join muscle to bone. So I thought it was worth putting in some treatment from the NICE guidelines. So most soft tissue injuries can be managed like this. Okay, so PRICE is the little mnemonic that you remember, and it's protection. So protect from injury by using a support or a high top or high lace-up shoes for ankle injury. Rest, avoid activity for 48 to 72 hours, because this is how long your body's natural inflammatory response takes to kick in following injury. Ice, apply ice wrapped in a damp towel for 15 to 20 minutes every 2 to 3 hours during the day for the first 48 to 72 hours. This is your acute inflammatory phase following the injury. This should not be left on whilst the person is asleep. Compression, with a simple elastic bandage or elasticated tubular bandage, which should be snug but not tight to help control swelling and support the injury. This should be removed before going to sleep. Tuber grip, I think, is sometimes called. It doesn't really have any sort of research-based efficacy, and a lot of places are not using it now, but nonetheless, this is in the NICE guidelines. And elevation, keep the injured area elevated and supported on a pillow until the swelling is controlled. If the leg is injured, prolonged periods with the leg not elevated should be avoided, because if it's injured and you have it dependent, if you have it hanging down, it will swell, and the swelling can be really very, very painful. So there you go. That's protect, rest, ice, compression, elevation, price. Thereafter, you should avoid harm. This is during your recovery phase. After this 48 to 72 hours, you need to avoid heat, okay, because heat can increase swelling and can make things a bit worse. Avoid alcohol, because that can increase your chances of bleeding. I'm not entirely sure the mechanism behind that, but equally you have more chance of falling over and really hurting yourself. Plus alcohol has a bit of an anaesthetic effect as well. Avoid running on the injured limb, because it will just make it worse. And avoid massaging it as well, because during the first sort of like 2 or 3 days and a week or so thereafter, you have, in essence, if you've torn a bit of muscle, you've got a blood clot in there, and if you massage that blood clot out, you basically put the healing process back to the very beginning again. So avoid harm. So price and harm. So on to kids. There is a condition called muscular dystrophy. It's part of a group of genetically inherited disorders. It's the most common type is called Duchenne muscular dystrophy. It affects 1 in 4,000 boys. It affects both sexes, but mainly boys. The problem happens with a chromosome that codes for a protein which maintains muscle cell walls. It leads to progressive destruction of the muscle cells. And the breaking down of the word anatomy is dys means difficulty with, and trophy is feeding. So the muscles have difficulty feeding, so they'll just sort of waste away really. There's a few different types as illustrated there. Again, this is just for information purposes. The grey areas tell you which areas are affected primarily. Don't worry too much about that, but know that muscular dystrophy mainly affects boys, and it's a group of genetically inherited. This illustrates how the sort of patients with muscular dystrophy get around. What they tend to do is push themselves up from the hands like that, with the legs then straight. That's called Gower's sign, and then they'll push up from the knees. This is because they have weakness. They have proximal muscle weakness in the proximal arms and legs. So from the second year, they might develop a bit of a waddling gait when they walk. Gait just refers to the way one walks, and they might get increasingly clumsy. The majority, unfortunately, tend to be wheelchair bound by 12 to 14 years. They'll eventually develop breathing problems, and most die in the late teens to early 20s, unfortunately. There isn't any cure, and it's irreversible. Okay, some important concepts to get across. As previously mentioned, tendons attach muscle to bone. So there's a picture of an Achilles tendon, which attaches the gastrocnemius insuleus to the calcaneum, muscle to bone. Ligaments attach bone to bone, like the anterior cruciate ligament that we mentioned very early on in this 1 hour 50 presentation. Atrophy means muscle wasting. So the left leg there is fine, but the right leg has some muscle atrophy. A means without, trophy means feeding. So if you don't feed something, it will get thin and waste away. Atrophy. Hypertrophy of muscle, where it can get really, really bigger. The picture on the far right is a joke. Nobody's that big, it's just sort of a special effects. But hypertrophy means it gets bigger, sort of lots of feeding, so the muscle will get bigger. Muscle contractures. So this is where if your patient's been in bed and immobile for a long time, you can see on this particular unfortunate patient, they've got quite a bit of muscle atrophy going on there, but they'll be left in bed. And what will happen when you lay in bed, you tend to bend your knees a bit, and the muscles get contractures in, so they just get stuck in that position basically, and that patient will probably never walk again. And if you look on the knees as well, there's some scarring that you can see, possibly from pressure sores that have occurred, and there's looks to be a dressing of the patient's hip there, and evidence of a catheter as well. So this is a really, really quite frail and ill person. We come to a quiz, right? Which of these are bones in the hand? Is the scaphoid a bone in the hand, cuboid, calcaneum, or pisiform? Which ones of those are bones in the hand? She looks too pretty, try to catch her. Answer is A and D. Okay, scaphoid and pisiform. Scaphoid, lunate, trichedron, pisiform, she looks too pretty. Try to catch her. Trapezium, trapezoid, capitate, and hamate with the hook of a hamatesman, like you hook some ham onto a hook. Okay, next question. There are how many thoracic vertebrae? 10, 12, 14, or 16? The answer is 12. Well done. 12 thoracic vertebrae and 12 pairs of ribs. That's just some x-rays illustrating some nicely labelled x-rays for you to become familiar with. Next question. Rheumatoid arthritis is progressive, symmetrical, degenerative, or a polyarthropathy. Which of those is correct? It's all of them. So there's a normal hand and there's a rheumatoid arthritis hand with what we mentioned before, the periarticular osteopenia, the joint erosions, and ulnar deviation. Next up, muscle functions. So, do they A, provide support, B, produce heat, C, facilitate locomotion, or D, they can become hypertrophic? In this instance, the answer is B, C, D. The support is provided by your bones. It's worth at this point just reiterating that your exam will be multiple choice, but there will only be one correct answer. Here I'm just mixing it up a bit just to keep you interested at 1 hour 53 minutes in. So the scapula, as beautifully illustrated there, is a long, irregular, flat, or short bone. If you paid attention, you should know that it's C, a flat bone. Oh, at this point, we say congratulations, you made it to the end of the musculoskeletal seminar. Very well done. That's how your brains might feel at the moment. There's this ball of knowledge that has been hurtling through space, and it's just slammed into your brain there like that, and it's gone deeper into your brain, and now it's going to consolidate, and it's connecting neurons all over your head, and it's probably time for a rest, and you've earned it. Well done. What I would advise you to do is to review this. You could even download it off YouTube or rip off the audio file and listen to it on your commute. So yeah, the benefit of the online stuff is that you can do it again and again and again, and doing things again and again and again benefits you because it goes in. So well done for making it this far, and best of luck in the exam.